Good afternoon, friends. Welcome to the virtual Lunch and Learn for One CME. I'm Susan Bray, the East Valley Navigator for Dignity Health, and your host today. Today we have Dr. Rachel Bond with us. Dr. Bond is a board-certified cardiologist. She is focused on women's heart health and has authored several articles referencing sex and gender differences and cardiovascular conditions that predominantly affect women. Along with opinion pieces, she's aimed at addressing health equity, reducing health disparities, and promoting the professional development of women and minorities in the health science profession. Today, Dr. Bond will be sharing some of that content with us and how it relates to your everyday practice. But first, we're going to go over a few housekeeping issues just to make sure that you're able to claim your CME following this discussion. So if you've joined us by computer, please click on your screen and then click the chat bubble that should appear at the bottom of your screen as you hover over it with your mouse. This will activate the chat box. Please put your email into the chat and we'll send you an email with instructions on how to claim your CME. Email will include a survey which is required in, of course, the CME world to claim this credit. If you're interested in future virtual CMEs, we can send out an email invite to you and a WebEx link. And this is also how we will return the CME to you. If you're calling in, please text me at 928-699-4797, or you can email me at susan.bray, and that's B-R-A-Y, at dignityhealth.org to get the instructions sent your way. As we go along with the presentation, please feel free to type your questions in the chat box. Those will be answered at the end of the presentation. And if you have joined us by phone, please just join us at the end for the question and answers. With that wrapped up, let's get to the good stuff, and I present to you Dr. Bond.
Thank you so much, Susan. So thank you all for having me this afternoon. Today I'm going to be talking about prevention in a nutshell. And the focus is actually going to be on women's heart health in relation to a lot of the risk enhancers. And the primary areas that I'm going to be focusing on are the 2019 prevention guidelines as well as the 2018 cholesterol guidelines, all to hopefully make your practice a little bit easier in terms of preventing cardiovascular disease. So to begin, I have no faculty disclosures. In terms of my, at the conclusion of this activity, I hope that participants will be able to, as Maid mentioned, evaluate the need for blood cholesterol management and primary prevention of any patient that has atherosclerotic cardiovascular disease by using the 2018 guidelines from the American Heart Association as well as the American College of Cardiology. I also hope that we develop individualized primary prevention strategies for patients with and without severe hypercholesterolemia using those same guidelines, that by the end of this talk, you'll feel comfortable implementing management plans for the secondary prevention of ASCVD using recommendations from the 2018 blood cholesterol guidelines, as well as sometimes the need to use non-statin therapy to ensure that our patients are at that threshold or below that threshold when we think about it for cholesterol. And also with these new non-statin therapies, some barriers in terms of, that we may see in terms of accessing it or for access to from our patients from an insurance perspective and how we can overcome those. So those are the hopes in terms of our learning objectives. So to begin, I actually wanted to start with a few simple pretest questions, and hopefully as we go through the talk, you'll feel comfortable in terms of the answers to these particular questions. So to begin, the first question, according to the 2018 blood cholesterol guidelines, a patient with which of the following is considered to have a very high atherosclerotic cardiovascular disease risk? Is it 1, hypertension and diabetes, 2, greater than 1 acute coronary syndrome in the last 12 months, 3, an LDL cholesterol greater than 100 milligrams per deciliter on maximally tolerated statin, or 4, symptomatic or asymptomatic peripheral arterial disease? As I said, we will go over the answers to these questions at the end of my talk. The second question, clinical outcome studies of PCSK9 inhibitors have reported which of the following in patients with peripheral arterial disease or polyvascular disease? Is it 1, increased adverse event rates in patients with peripheral arterial disease compared to those without peripheral arterial disease, similar reductions in LDL cholesterol and atherosclerotic cardiovascular disease event rates in patients with or without peripheral arterial disease. 3, reductions in ASCVD event rates related to intensity of background statin therapy. Or 4, greater reductions in ASCVD event rates in patients with more extensive vascular disease. Question number 3. Doing which of the following may improve the chances of prior authorization for PCSK9 inhibitor therapy? Is it 1, order an LDL cholesterol fractionation, 2, conduct a carotid Doppler and include results, 3, include a letter from a patient confirming adherence to therapy, or 4, provide hospitalization records for patients with a history of ASCVD? Question number 4. We have a 70-year-old man. He has a history of peripheral arterial disease with claudication, meaning he has symptoms in his right lower leg when he walks. We do an ankle brachial index, and it's 0.75, which is significantly abnormal. He also has a history of hypertension, type 2 diabetes with an LDL cholesterol of 82, and he currently is on rosuvastatin 40, which is the highest dose when we think about it for rosuvastatin. This patient with a history of PAD, clearly with an LDL cholesterol of 82, puts him above the threshold, which for him should be 70 or less. So which of the following would be appropriate at this time? Would we, 1, prescribe ezetimibe, 2, switch him to atorvastatin 80 milligrams, 3, request prior approval for PCSK9 inhibitor therapy, or 4, maintain him on the current therapy because he is near recommended LDL cholesterol threshold? So again, hopefully by the end of my talk, you'll be able to answer these questions without really any thought. So to begin, I thought it would be interesting for us to start with a case, and this case is going to really walk us through the secondary prevention when we think about cardiovascular disease. So let's meet our case study. Our case study is Rosa. She's a 66-year-old Hispanic woman. She has a history of an inferior wall myocardial infarction that she obtained about 4 years ago, for which a drug-eluting stent was placed to her right coronary artery. She's been treated for about 10 years for high blood pressure on an ACE inhibitor where her blood pressure is very well controlled at 120/72. At the time of her myocardial infarction, she was placed on 80 milligrams of atorvastatin, and she now is also on just a daily aspirin. Her LDL cholesterol has been deemed to be quote-unquote well-controlled since, but when we check her labs, we notice that her LDL cholesterol is 84 milligrams per deciliter, her triglycerides are 122 milligrams per deciliter, her HDL is 62 milligrams per deciliter, and her total cholesterol is 170 milligrams per deciliter. She states to be eating a heart-healthy diet and exercising about 4 times a week, and her body mass index is 26, which is slightly above the ideal, which is less than 25, placing her in that overweight category. So the first thing that should really come to mind when we see this case is we know that Rosa is a high-risk patient. She's a high-risk patient because she had an inferior wall myocardial infarction. And thus, when we look at her LDL cholesterol, we know that her cholesterol of 84 is above the threshold of 70 or less. So the first thing that we as clinicians should really be honing in on is, well, what about diet and lifestyle? Of course, we're going to get into the medications, but really the 2018 guidelines on the treatment of high blood cholesterol wants to use diet and lifestyle as a cornerstone for risk reduction. And when we think about an ideal diet, particularly one that lowers cholesterol and lowers overall cardiovascular health, it should be an anti-atherogenic plant-based diet consisting of fruits, vegetables, whole grains, legumes, nuts, lean proteins, and liquid vegetable oils that's very much so low in added sugar or sodium. The guidelines also stress the fact that we need to ensure that we counsel our patients on avoiding tobacco use, excessive alcohol use, and of course engage in regular exercise. So based on the American Heart Association, it suggested that our patients do at least 150 minutes per week of moderate intensity activity. And that could be even including briskly walking. So we want to first make sure that the cornerstone of risk reduction, diet and lifestyle, are being met by our patients before we even start to delve into the need to lower their cholesterol with other measures. And this really brings the question of how are we doing in terms of making sure that our patients have ideal cholesterol levels. And when we looked at this over and over, this actually looks at data from 1988 to 2014. We see that the mean serum total cholesterol levels in adults have decreased steadily really from the 1980s all the way to 2014 in adults greater than 20 years of age. Despite that, however, lipids remain a key modifiable risk factor. And when we separate it into sex, we see that the male sex, it accounts for about 58% of a first acute myocardial infarction in a young adult, anyone above the age of 20. For women, it's about 52%, so it's really nearly as much as we see with high blood pressure. So it is a very common risk factor, and it's also a common modifiable risk factor, meaning something we can change that helps to make heart disease 80% of the time preventable. Now, as I made mention, the cornerstone when we think about it really needs to be lifestyle modification through diet and exercise, but sometimes that's not enough, and we know that there are medications out there that can lower our cholesterol, particularly the LDL cholesterol, which we in the cardiology world focus much more on because we know that that is the cholesterol that basically encompasses the majority of cholesterol in our body. And the lower the LDL, the better in terms of lower event rates. This has been shown in several key landmark trials, and we see that the lower the cholesterol being here on the x-axis and on the y-axis event rates, then the lower you have an event rate. Now, despite us knowing this as clinicians, this graph here really paints the picture of where we are today, because despite us knowing that the use of a statin, particularly for somebody that is high risk, meaning somebody who has atherosclerotic cardiovascular disease, we still may not have patients on a statin. And we see that about a third of the time patients are not on a statin, nearly 30% of the time in all groups, particularly when we look at those that have confirmed atherosclerotic cardiovascular disease. And it really asks the question why, because we see that statins, in terms of where it's been proven to reduce risks, include those patients that have had an initial event, an ASCVD event, meaning that they had a heart attack of some sort or some form of coronary artery event where they were revascularized, or we know that it's proven to reduce risks in those that have recurrent events, as well as peripheral arterial disease and amputation. And I stress peripheral arterial disease because I can say that as clinicians, we don't do as well a job in lowering the cholesterol levels for those patients that have peripheral arterial disease as we do for coronary artery disease. And we have to understand that peripheral arterial disease is a risk equivalent to coronary artery disease, and it should be treated the same, which is very aggressive lowering of your LDL cholesterol. Where statins have not been proven to reduce risk is in heart failure. If you have somebody who has a valve that's calcified in terms of preventing the progression of that disease, or even in dialysis patients that have known atherosclerotic cardiovascular disease. And some reasons why our patients are not on high-intensity statins could span anywhere from the fact that, for the most part, there may be an intolerance to the statin. What I can tell you is for a true statin intolerance, it's really only in about 10% of the population. All of the other side effects that we think about are not per se intolerances, but things that we can hopefully work with our patients to help modify. And I'm going to delve into kind of some of the ways that we can best practice or some of the approaches we can best do to kind of get over these side effects that we sometimes see with statins. It also could be lack of patient adherence. This has been looked at in multiple studies, and what we most recently have seen that within 6 months of our patient population being started on a statin, nearly 50% are no longer on the statin. And we have to really paint the question as to why, and I'll be talking about that as well in the next upcoming slides. We also know that another reason may be patient preference for other treatment. Less likely cost, particularly now, is a vast majority of statins, even our high-intensity statins that are ideal, particularly for secondary prevention, are generic now. And also ineffectiveness. And this is an important one because we as clinicians don't per se think about this when we're starting a patient on a statin. And I say that because this was looked at in the Jupiter trial. Jupiter was a pivotal trial that looked at the use of high-sensitivity CRP for the treatment of those for primary prevention with the use of a statin. And if we were to put them on a statin, if they had an elevated CRP, would that reduce event rates? And it actually concluded that it would. But what they also looked at was if they provided somebody with a placebo medication versus a statin, and if they, of course, had a greater reduction with that statin, they had a lower event rate versus somebody who had no reduction or actually an increase in terms of their LDL cholesterol. Their event rates were higher. So what this really painted was is that even if you give somebody the same dose and the same type of medication, they may respond different to it, which implies that there's a variability of response. And it's important for us as clinicians to determine this. The only way to do that would be to recheck your cholesterol levels. Now, I talked about the fact that a big part of why, or a large part of why, patients are not currently on high-intensity statins when they should be are side effects. And as I made mention, when we think about the more scarier types of side effects like the myositis or the myopathies where your CPK levels are very elevated, similarly the rhabdomyolysis or even a statin-induced autoimmune myopathy, these are extremely, extremely rare. Even myalgias, when we think about it, where the patient, which is really the more common side effect that I hear in my practices, where they have those muscle aches or pains or that joint ache or pain, it's very infrequently seen in randomized controlled trials, but when we look at observational studies, it's much more frequent. And it really depends on our patient population, because we know that myalgias are more common in the extremes of age, so the younger population or the older population. I highlight the female sex because that's also pivotal. Females tend to have are more likely to have these side effects such as myalgias. We also know somebody with a low body mass index, anyone on a high-risk medication that may interact with the statin therapy, or if they have comorbidities like HIV, renal, liver, thyroid disease, or any pre-existing myopathy, Asian descent as well, anybody that does partake in excess alcohol or high levels of physical activity or trauma. So these are the patients that we want to look out for, and maybe we want to educate on the fact that they may experience this and they need to let us be aware without stopping the medications on their own, but perhaps working with us to figure out other options that we could use. Now, one side effect that has been, I think, brought to the attention more recently is concern for diabetes. And what I can say is that it really depends on the population. Overall, this has been looked at from randomized controlled trials as well as meta-analyses, and we see that there is a correlation, although rare, but it really depends on the population, as I said. So it's more frequent if you have somebody that has a risk factor for diabetes, such as somebody with a body mass index above 30, which implies that they would be obese, or somebody with a fasting blood sugar above 100, or if there's evidence of metabolic syndrome or a hemoglobin A1C above 6%. So in this population, they are at the greatest risk. So again, the vast majority of our patients that are on this, what I usually say to them is we know that statins will save your life, particularly if you had a heart attack, because it's going to help lower your LDL cholesterol. There may be a chance of it causing diabetes, but that's a chance I would be willing to take if I know that this statin is going to potentially prevent me from having another cardiac event or a cardiac event in general. Other side effects that we think about are liver disease. So we know that the liver or statins are passed through our liver. These side effects are very infrequent or rare in terms of causing elevations or even hepatic failure, for example. So much so that the new guidelines stress that we no longer have to check a hepatic panel immediately after we start somebody on a statin or we change the dose of the medication. We can probably just check it every 12 months or so, or as deemed appropriate by the primary care physician. Another side effect that has also gained a lot of, I think, attention has been concern for memory or cognitive impairment. Again, very rare, and really the frequency remains unclear, and this has only been shown in case reports. And actually more recently, randomized controlled trials have shown that statins may help with cognition. So this is something that I do stress to my patients. We also know that cancer, there's no definite association, as well as renal dysfunction, cataracts, tendon rupture, hemorrhagic stroke, interstitial lung disease, or changes in our hormonal levels. So side effects, for the most part, relatively rare. But let's say we have a patient that is adamant that they're having this intolerance and they don't want to participate or continue the use of their statin. Well, what is the approach that I typically do? We want to maybe de-challenge them, right? So what does that mean? We want to do a step-by-step approach to decrease the dose of their statin, and maybe they'll have the same benefits on a lower dose in terms of getting them below that threshold where their LDL needs to be, and we can get rid of those symptoms. We also may want to consider using intermittent dosing, right, where we do an alternate statin dose every day, so maybe Monday, Wednesday, Friday, for example. Eventually, if that doesn't work as well, we may also want to consider switching their statin. So we know that the lipophilic statins like atorvastatin or lovastatin or simvastatin sometimes can cause a lot more of those myalgias, particularly in certain populations, so elderly and females, for example. So maybe we want to switch them to a more hydrophilic statin, which is pravastatin or rosuvastatin. And if we do that, perhaps there would be a better tolerance to that for our patients. We also talk about the use of a supplement, which is coenzyme Q10. I can say that I do suggest the use of coenzyme Q10 to my patients because we know in about 1 in 30, it does help with those myalgias. However, it would have to be at a dose of 200 milligrams a day or greater. What I can state, though, is that the guidelines suggest that there really hasn't been any proven benefit, so they're suggesting perhaps not to use it or suggest it in your patients. That being said, we want to, of course, the guidelines are there to help us, but they're not per se there to tell us how we should practice. And that's why you really want to think about your patient population and decide maybe I want to see if coenzyme Q10 will help them because we know that it may be beneficial for other cardiovascular risk reduction as well. Now, in order for us to see if, one, our patient is adhering to their medication, or one, even if their response to the medication is what we would want it to be, we have to, of course, repeat their cholesterol levels. And the guidelines suggest that we really should recheck it within 4 to 12 weeks after we initiate the dose, or if we adjust the dose. Once we're at that level we want our patient's LDL to be, we then can repeat it every 3 to 12 months. And again, the purpose of this is to really define the response to lifestyle and statins by the percent reduction in LDL compared to baseline. We also want to then see, well, maybe if our patient on that statin, that highest tolerated statin, is not below that threshold where they should be, particularly if they have known ASCVD, and we know that level is 70 or less, then maybe we need to talk about adding a non-statin therapy. So before we delve back into our case, what about fasting versus non-fasting? And I get asked this question a lot, not just by clinicians, but my patients. So luckily, the guidelines have suggested that in adults above the age of 20 years old who are not on a lipid-lowering therapy, it is okay for us to check their cholesterol levels, either fasting or non-fasting. We don't have to starve our patients anymore. And that's because our LDL really doesn't fluctuate very much with food in our system. What does fluctuate, however, is triglycerides. And if our initial non-fasting lipid profile included a triglyceride above 400, we would want to repeat that to really see, is that a true level, or is that because they just had a burger, for example? So this is really the only situation we would have our patients come back to have a non-fasting or having to have a fasting lipid panel. So let's go back to our patient, Rosa, just to kind of summarize her again. 66, Hispanic woman, history of an inferior wall MI 4 years ago. They treated her appropriately with a drug-eluting stent to her right coronary artery, and her LDL remains at 84, again above threshold 70 or less. So we then ask her about her adherence to her statin therapy, and she says, yes, doctor, I've been taking it religiously. She also says that she's been dieting as she should and exercising well. So after we go through the cornerstones of lifestyle modification, we then decide to start her on ezetimibe, 10 milligrams. Now, we see that a vast majority of patients that have atherosclerotic cardiovascular disease remain to have a very high risk for recurrent events despite the use of statins. And we see this time and time again because there's that residual risk. Either it may be because of the fact that they have a variable response to the statin, which leads us to the fact of, well, let's focus in on sort of the right side of this graph. I know it's very, very busy, but it really paints the picture of secondary prevention utilizing the lipid cholesterol guidelines. And what do they say? If you're on a maximal statin and your LDL cholesterol remains above or equal to 70, you want to first consider the use of ezetimibe. After the use of ezetimibe, and once they're still on a maximally tolerated statin, you may then want to consider the use of PCSK9 inhibitors. And one reason why ezetimibe in the 2018 guidelines perhaps was the first agent of choice over the newer PCSK9 inhibitors was because at the time, ezetimibe was deemed to be much more cost effective. The 2018 guidelines came out before there was a drastic drop in the pricing of PCSK9 inhibitors. So right now, really in real practice, it depends on the patient's insurance, but a lot of times you can initiate the use of PCSK9 inhibitors over the use of ezetimibe. But to follow the guidelines, we see that the guidelines in 2018 at least used ezetimibe first if their LDL remained above that threshold, and then the use of PCSK9 inhibitors if it still remained above that. And the reason ezetimibe has such an impact, particularly in acute coronary syndrome, is because of this pivotal trial called IMPROVE-IT. What IMPROVE-IT looked at was about 18,000 patients with acute coronary syndrome, and they were randomized to either simvastatin or simvastatin with ezetimibe. And what they looked at were actually over a 7-year period. One, was there a reduction in the mean LDL cholesterol from the group that was on just simvastatin alone versus simvastatin and ezetimibe? And also, was there a reduction in event rates? And to answer that question, there was about a 15 milligram per deciliter reduction in terms of the level of LDL cholesterol, but more importantly, we saw a 2% absolute risk reduction in event rate. So with the addition of ezetimibe, we were saving lives. We were preventing a heart attack. We were preventing a recurrent heart attack. And this is why Rosa, our patient, was started on ezetimibe herself. But like I mentioned, once we start you on a medication, we have to see, is that medication effective? So after about 4 to 12 weeks or so, we decided to repeat Rosa's cholesterol, and her LDL cholesterol went from 84 to 74. So although there was a drop, she still remains above that threshold for somebody like Rosa who is high risk, which is 70 or less. So then this leads to, well, what do? We have to then talk about our PCSK9 inhibitors. So we have currently to date 2 FDA-approved PCSK9 inhibitors. One is ALIROCUMAB or Praluent, and the other is EVOLOCUMAB or Repatha. The indications are relatively similar for both in that after the use of diet, exercise, and a maximally tolerated statin, if the LDL remains above that threshold and you have a patient who has heterozygous familial hypercholesterolemia or known clinical atherosclerotic cardiovascular disease, then you can consider the use of Praluent. If you have a similar patient, but also in addition homozygous familial hypercholesterolemia, which I'll be talking about in a little bit, then you also consider the addition of an agent such as Repatha. And we can see that really honing in on the side effects, they're rather rare, majority of which actually are more localized to the site because it is a monoclonal antibody, so it has to be injected, and the injection is anywhere from every 2 weeks to every 4 weeks, depending on the dosage that we use and the route. But the overall side effects include maybe an injection site reaction, which is very local, or a hypersensitivity reaction, or even a nasopharyngitis where they may present with having like an upper respiratory tract infection. Sometimes we can also see in our patients at the very beginning stages some of that muscle discomfort, because if you could imagine, the use of a PCSK9 inhibitor with a statin can lower your LDL cholesterol by over 60%. So all of that LDL cholesterol is released from our body, even our muscles, and it could cause that pain that they may feel the first 1 to 2 weeks, but that pain typically goes away. Now, one thing that I wanted to emphasize were the key cardiovascular outcome trials that really showed that EVOLOCUMAB and ALIROCUMAB, how effective they were in lowering endpoints such as cardiovascular death or ischemic stroke or rehospitalizations or unstable angina. And the Repatha trial or the EVOLOCUMAB trial was the FOURIER trial, where they looked at about 27,000 patients. They looked at patients that had stable atherosclerotic cardiovascular disease with high-risk features. The average age was about 60, and these patients were on a moderate intensity statin, which is atorvastatin 20 milligrams or higher. For the most part, the majority were on a high-intensity statin when we looked at the statistics of nearly 70%. And they all had an LDL cholesterol, about 92% of them had an LDL cholesterol above 70. And again, the endpoint was primarily cardiovascular death, stroke, revascularization, or hospitalization, and these patients were followed for 26 months. The ODYSSEY trial, which was ALIROCUMAB's trial, looked at roughly almost the same sample size. It was almost 20,000 or so. These patients were looked at about 4 to 52 weeks after they had an acute coronary event. The average age was about 58. They as well, the vast majority were on high-intensity statins. vast majority had an LDL above threshold of 70 or less, and the primary endpoint that was looked at too was death from coronary heart disease, myocardial infarction, ischemic stroke, or hospitalization. And to put it into perspective, this is the FOURIER trial with EVOLOCUMAB. What we see is that there was a 59% mean reduction when you compare the placebo group to the group that received EVOLOCUMAB in terms of the reduction or lowering of LDL cholesterol. That's an absolute reduction of about 56 milligrams per deciliter. And when we look at this overall, from a absolute risk reduction, we see that in terms of the event rate, such as cardiovascular death, MI, stroke, hospitalizations, it went from 14.6 to 12.6, which is about a relative risk reduction of 15%, which is major. Similarly, before we get into the ODYSSEY trial, one thing that more recently has been looked at was, well, how efficacious is it and how safe is it to get our LDL cholesterol less than 10? Because what these new non-statins are telling us is that the theory of that if you have cardiovascular disease, you should put someone on a statin. Your risk of having a recurrent cardiac event is completely zero just by being on a statin. That theory has been thrown out the window, right? We know that it's not just a statin per se. We know that it's the lowering of the LDL cholesterol. With the lower the LDL, the better. So is there a point in time when your LDL is just too low and it becomes unsafe? And this has been looked at, and we see that for those with an LDL above 100, which is the orange bar, compared to those with an LDL below 10, which is the blue bar, your percent of patients that had a cardiovascular event, such as a myocardial infarction or stroke, is significantly lower with a lower LDL cholesterol. But it also implies that we see this irrespective of side effects, which is fantastic, right? So the side effects are rather similar to somebody with an LDL above 100 as it is to an LDL below 10 in terms of serious adverse events, as well as all adverse events. So what this tells us is that in theory, we can probably have LDL cholesterol less than 10. For the vast majority of my patients, I typically like to keep them in the double digits. If they're in the single digits, there's really no particular reason we have to per se keep them there as long as their LDL remains below that 70 threshold. And sometimes, depending on if they have other high-risk features, I may even use a threshold of 50 to 55, which is more of the European guidelines, as well as the Association of American Diabetes Association, I should say. They have actually lower thresholds than the American College of Cardiology. So for the most part, we know that having LDLs less than 10 can be safe. We know, of course, we need cholesterol to function and cognate, so we don't want it to be zero, however. Which then leads us to the ODYSSEY outcomes, which is with ALIROCUMAB or Praluent. And what we see is that similarly, there was about a 55% overall reduction in LDL cholesterol in the placebo group compared to those that are on ALIROCUMAB. And what does that translate into in terms of cardiovascular composite endpoints? Very similar to FOURIER, is that there's about a 2% absolute risk reduction or about a 15% relative risk reduction. One thing I wanted to bring into your attention is we see that the graph towards the end of the trial started to go in the wrong direction, or there was this sort of upward drift. And this upward drift was felt to be likely due to a protocol-mandated discontinuation of therapy for LDL less than 30. So this trial came out before we really studied patients that had LDLs less than 20. And in the past, there was concern that if you had such a low LDL, it could affect you. So they made a mandate that if the LDL dropped below 30, they had to stop the ALIROCUMAB medication. So that's really the disclosure that this trial highlighted, where we see that upward trend. But overall, very, very similar data in both PCSK9 inhibitors, which then brings me to, well, who benefits the most from these PCSK9 inhibitors, or even ezetimibe, which again are non-statin ways to lower your LDL cholesterol? It is this very high risk of ASCVD. And how do we define very high risk? So the way we define it is somebody who has greater than one major ASCVD event. The way we define ASCVD event is a recent acute coronary event within the past 12 months, a history of myocardial infarction other than that recent acute coronary event above, a history of an ischemic stroke, anyone with symptomatic peripheral arterial disease where they have claudication and an anchiobrachial index less than 0.85, or they had previous revascularization or amputation. The other way we define very high risk is somebody who has one major event as above or one high-risk condition. So these high-risk conditions are listed here. We know that as we age, our risk for cardiac disease increases, particularly for those above or equal to the age of 65. We also know that somebody with familial hypercholesterolemia is a risk factor as well, and I'm going to be touching upon that as I made mention earlier. Anyone with a prior CABG or PCI outside of the major ASCVD event, a diabetic, somebody who has hypertension, anyone with kidney disease, a current smoker, or if you have a persistently elevated LDL cholesterol above 100, as well as a history of congestive heart failure. These are all very, very high-risk patients. Now, another very high-risk patient, I keep wanting to really stress peripheral arterial disease because I, again, need to emphasize the fact that we as clinicians don't do as good a job in focusing in on their LDL cholesterols or their overall cholesterols, and we have to do a good job because we want to prevent adverse limb events, and we also want to prevent the need for further revascularizations. And sometimes we want to ensure that our patients' legs don't have to get amputated off. And one way to do that is to ensure they're on all the proper medications. And this has been looked at in FOURIER. FOURIER, again, which is our Repatha group, where patients with PAD versus no PAD had a much had a greater benefit in terms of reducing a primary endpoint of cardiovascular death, MI, or stroke. So if we had patients with a very low level of LDL cholesterol, which is a median of about 31 milligrams per deciliter on EVOLOCUMAB or Repatha, particularly if they had symptomatic peripheral arterial disease, it significantly reduced their MACE events. We also know that it reduced their major adverse limb events, really without offsetting any side effects. So very, very important. This similarly was looked at in ODYSSEY, and ODYSSEY took it a step further, not just focusing on peripheral arterial disease, but also focusing on polyvascular disease, meaning multiple vascular systems that have disease within it. And we see that the largest absolute benefit from ALIROCUMAB or Praluent was those that had the largest number of vascular beds that had disease. So if you had one vascular bed versus three vascular beds, your three vascular bed patient benefited the most from the use of this non-statin therapy. So we don't want to forget about our peripheral arterial disease patients in terms of aggressive treatment, which then leads me to prior authorization, because I get asked this a lot by several clinicians. Hey, Dr. Bond, I know that my patient is not at that threshold or below that threshold because they had a cardiac event, but it's very hard for me to get approval from the insurance for the PCSK9 inhibitor. So what can I do? And before we talk about what you can do, I want to really highlight that you're not alone in terms of this prior authorization. Although it has gotten better, there are still several prescriptions that have remained rejected. And when we look at this data, we see that about 83% of prescriptions for PCSK9 inhibitors are initially rejected. Ultimately, about 57%, which is a large part of our population. Approval tends to be more likely among those that are already on a high-intensity statin or ezetimibe, likely because the guidelines suggest ezetimibe first, as I touched upon. We also know that there are higher rejection rates observed in women, racial minorities, and lower socioeconomic status. So there's this implicit bias that we in the cardiology world are trying to educate our insurance companies about. Why are we not providing these medications that we see are life-changing to certain populations? And this is something that we need to advocate for and change. We also know that individuals that are in the rejected or abandoned cohort have significantly higher rates of cardiovascular events compared to those that actually their insurance company will pay for it, regardless if it's used for primary prevention from familial hypercholesterolemia or from secondary prevention for ASCVD. So we obviously see that there is a benefit, so we need to work with our insurance companies. So let's go back to our case and see. As we said, we wanted to prescribe a PCSK9 inhibitor to Rosa because even though she was on ezetimibe, her LDL cholesterol still remained above threshold. Unfortunately, her insurance rejects her. We then decide as doctors that we're going to do an appeal because we know that this is life-saving for Rosa. So when we're doing an appeal, common reasons for denial of a PCSK9 inhibitor include all that are listed. And this is really where it can change our practice in terms of if we clearly document why the PCSK9 inhibitor is indicated. So if we write this clear indication in our note, document any specifics that helps the insurance company understand why we're prescribing it, then we're more likely to get approval. So you may want to even provide hospital records. So for Rosa, for example, providing hospital records of her coronary catheterization that show that she had a blocked artery and a stent was placed may be all the insurance company needed to get that approval. If we have somebody who we're prescribing it for a primary prevention because they have familial hypercholesterolemia, you may want to document criteria for quote-unquote definite familial hypercholesterolemia. You know, they suggest maybe using genetic testing, but that's in less favor at this point in time. You want to also maybe submit office notes or labs with your prior authorization request. You want to document the patient's dietary, weight management, and exercise regimen. You want to also document that the patient was re-challenged if they were deemed to be statin intolerant. You may want to try ezetimibe and or other bile acid sequestrants, and you want to document that there's 80% compliance in full history for a statin and ezetimibe over a 12-month period. You may also want to document that the patient will continue to receive their maximally tolerated statin or ezetimibe while on the PCSK9 inhibitor. And a lot of times, insurances won't cover it despite the fact that the patient has ASCVD if their LDL is less than 100, or if they don't have ASCVD if their LDL is less than 130. So these are common reasons for denial. So what did we do with Rosa? We decided that we were going to provide thorough documentation on the appeal, including her hospital records that demonstrated that she did in fact have an inferior wall myocardial infarction and a stent was placed. With that, her PCSK9 inhibitor was approved. So she currently is now on her maximally tolerated statin, she's on ezetimibe, and she's maintained on a PCSK9 inhibitor. We then, as I said, because you want to make sure that she's responding to these agents, we then checked her LDL cholesterol again, and it went from 74 to 39. So she's well below that threshold, and Rosa most likely will have a much lower rate of having a recurrent cardiac event. So such an important and pivotal thing, but we also don't want to give up on our patients when we know that these medications can help them. So let's talk about primary prevention. We're going to be changing the topic a little bit. So with primary prevention, and this really leads us to the 2019 primary prevention guidelines, a big part of it were, hey, we as doctors need to be more patient-centered. And one way to do that is to have a team-based care approach. So what does that mean? We want to really work with, if I'm a cardiologist, work very closely with my primary care physician to ensure that we're all on the same page in terms of what is the best treatment management for our patients. We also want to include the patient in the conversation where we have a shared decision-making. And the only way to do that is to understand our patients culturally. And one thing that I think is so important that was added to the primary prevention guidelines is social determinants of health. And I'm going to go through a few examples of social determinants of health because these are key things that we should be looking at routinely when we see our patients, particularly for their wellness visit. So common social determinants of health when we think about cardiovascular risk are psychosocial stressors. We should be routinely assessing and providing counseling for our patients. Particularly as we know, stress may affect different groups much higher than other groups. Particularly women tend to have higher rates of chronic emotional stress, anxiety, or depression, and it can double their risk of having a cardiac event compared to their male counterpart. So we really want to hone in on these psychosocial stressors. We also want to ensure that our patient understands their medical condition because then they're more likely to comply with your recommendations. You wouldn't be surprised, I think, to understand that if you tell somebody that they're having an acute coronary event, they may not understand what that means to them. If they have a blocked artery, they may not understand what that means to them. So really honing in on what their understanding of their medical condition is so, so important. We also want to think about social determinants of health in terms of diet. So we may prescribe them a diet, right, a more plant-based diet, but do they even have access to foods such as that because of the community that they're living in? Or even economic factors. Can they financially afford such a diet, for example, right? When we think about more inner cities or rural environments, they may not have the supermarkets that we have in other areas. They may have more smaller local markets that don't per se focus in on plant-based, or they may have an abundance of fast food. So we have to understand why they may not be complying with their diet. Similarly, exercise and physical activity. Perhaps their neighborhood environment doesn't provide them access to facilities for physical activity, either it be a gym because financially they can't afford it, or even a park or a community where they can actually walk. So we really want to determine this when we interview our patients on a regular basis. We know that it's important because, as I made mention in the earlier talk, when we were talking about secondary prevention, nutrition and diet is so, so important. So a diet, again, I can't stress this enough, really a plant-based diet has been the diet that has been most effective in lowering one's risk of cardiovascular disease. And we want to replace any saturated fats with those monounsaturated fats like the omega-3s, and that's where fish comes into play. So the oily fish, such as the salmons and the tunas and the herring. We also want to reduce the amount of cholesterol and sodium in our diet as well. So nutrition is such an important part of primary prevention. And one group, when we talk about primary prevention, that I'm going to be starting with is this group, which is those patients after we check their cholesterol who have an LDL cholesterol above 190. This is a very, very, very high risk group. And because of that, the guidelines suggest that these patients automatically, irrespective of any other risk factors, should be immediately placed on a high intensity statin to get their cholesterol to a much better or appropriate level. And the vast majority of patients that have an LDL cholesterol above 190 are patients that have familial hypercholesterolemia, or FH. Now, FH is not as an uncommon disease as we thought in the past, in that about 1 in 250 have either probable or definite familial hypercholesterolemia. And this is a genetic, autosomal dominant, inherited trait where we know that it can increase your risk of a cardiac event by 20-fold compared to the general population. And we know that it could cause an acceleration in cardiovascular disease that's a little bit different if you're a female versus a male. In a male, it can accelerate it by 10 to 20 years. In a female, about 20 to 30 years. This graph very nicely depicts what familial hypercholesterolemia can do to you in terms of your LDL cholesterol, but also in theory, your event rate. And we know that if you have homozygous familial hypercholesterolemia, this is autosomal dominant, again, and in this population, they normally present in their second decade of life, usually with a heart attack. So very, very scary. And these are people in their 20s or so that have cardiac conditions. The vast majority of these patients that are presenting in their 20s with a heart attack, despite having a heart attack, are still less likely to be appropriately treated in terms of getting their cholesterol to the level it needs to be. So we have to do a better job in not just screening our patients, and that's why the guidelines, I think it's so important that they added different age groups, which I'm going to be talking about in a little bit as well, but also making sure we're managing our patients well and accordingly. Now, what about our heterozygous familial hypercholesterolemia? So these patients usually present more in their middle age. But what do we see? We see that if we were to start somebody on a statin, right, once we diagnose them with heterozygous familial hypercholesterolemia, and the only way to know if they have it is to check their cholesterol. Of course, taking a good family history is important as well, because if this person had family members at a young age having heart conditions or dying from heart disease, this may be one theory to say, hey, maybe I need to check their cholesterol, even though they're in their mid-30s or early 40s or late or so. But when we start them on a statin, we can drastically alter the course of coronary heart disease to the point where it's equivalent to somebody who does not have familial hypercholesterolemia. So that is such, I think, a strong statement to say that these medications can be life-changing for these particular patients, particularly because we know that diet and lifestyle alone are not going to be enough for these familial hypercholesterolemics to get their cholesterol to the levels that we need them to be. Now, in any adult with an LDL cholesterol above 190, as I said, this is our high-risk group. If they have familial hypercholesterolemia, or if they just are unfortunate and have that LDL cholesterol above 190 for what other reason it may be, we want to start them on a high-intensity statin with the intent to lower their LDL cholesterol by greater than 50%. If their cholesterol remains above 100, after maximizing that statin, you then maybe want to consider the use of ezetimibe if reasonable, or even the use of a PCSK9 inhibitor if they meet criteria from a primary prevention perspective, being familial hypercholesterolemia. Now, what about the other groups that benefit from the use of statins? And I can't speak enough about patients that have diabetes. We in the cardiology world really talk about diabetes as a coronary artery disease risk equivalent. So we want to be as aggressive in lowering their cholesterol as possible. So any diabetic who's between the age of 40 to 75 who should be placed on a moderate intensity statin, particularly if their LDL cholesterol is between 70 to 190. Now, there are some situations when we would decide maybe they don't just need a moderate intensity statin, but they need a higher intensity statin. And what are those patients? So this is where these sort of risk enhancers come into play. And you're going to hear me talk about these risk enhancers later on when we talk about the use of our calculation for patients that don't fall into the category of an LDL above 190 or don't fall into the category of being diabetic between the ages of 40 to 75. So these risk enhancers where you are a diabetic and maybe you need a more aggressive lowering of your LDL cholesterol with not just the use of a moderate intensity statin, but maybe the use of a higher intensity statin is if you are diabetic for a longer duration. So we know anybody who's had diabetes, type 2 diabetes in particular, over 10 years places you at a much higher risk for a cardiac event. If you're a type 1 diabetic over 20 years, that places you at a higher risk. We also know anybody that has albumin in their urine. Anybody with evidence of kidney disease, retinopathy, neuropathy, or going back to our anchiobrachial index, anybody who has an abnormal anchiobrachial index less than 0.9 also places you at a higher risk, and we may want to consider the use of a high-intensity statin. Now, what about that patient population, again, that does not fall into that LDL cholesterol above 190, or if you're a diabetic between the ages of 40 to 75? We then, as clinicians, if you're between the ages of 40 to 75 without diabetes and without an LDL above 190, should be using our calculation, our ASCVD pooled cohort equation to help us as clinicians determine what their risk is. Is their risk low? Is their risk borderline? Is their risk intermediate? Or is their risk high? And that's the next thing that I'm going to be touching upon. So again, is their risk low? Is their risk borderline? Is their risk intermediate? And is their risk high? And this equation looks at your age, it looks at your LDL cholesterol, it looks at your total cholesterol, it looks at your blood pressure, it looks at your gender, and it looks at if there is use of aspirin or not, and if you're on any blood pressure medication. And it then comes up with a number, and it puts you into one of these four categories. And I want to talk about the extreme categories because those are the easiest as clinicians for us to figure out the best management opportunities for. So if after estimating our pooled cohort risk, which again looks at your 10-year risk of having a cardiac event, and you're deemed to be low, that is ideal. That's what we want all of our patients to be a part of. Then we know that all we have to do in terms of educating our patients is with lifestyle modification. Again, lifestyle being the cornerstone, so diet, exercising, not smoking, limiting your alcohol use, et cetera, et cetera. But what about the other extreme, our high-risk group? So if you are high risk, then you are at over a 20% risk of having a cardiac event in the next 10 years. So we would not just be focused on your lifestyle, but we would also talk about drug therapy. So these patients are the patients that we would talk about starting them on a statin, starting them perhaps on a baby aspirin. But what do we do for that borderline or intermediate risk group? And that's where, with the prevention guidelines, we really want to talk about shared decision making. So we have our clinician-patient discussion considering risk-enhancing factors and kind of weighing the benefits of starting them on a medicine versus the risks of starting them on a medicine. And we may also consider the use of a calcium score, and I'm going to be talking about both of those. So what are these risk enhancers that we talk about that may make us as clinicians more inclined to start our patients on medications to lower their cholesterol? So the first one is a family history of premature ASCVD. So the way we define that is anybody who has a first-degree relative, if you're a man, that had a cardiac event before the age of 55, or if they're a female and had a cardiac event before the age of 65. If we have somebody who has a persistently elevated LDL cholesterol above 160, we may want to be more aggressive in lowering their LDL cholesterol. To the same effect, if you have kidney disease, metabolic syndrome. Now, I highlight these two areas here because I think that this was so so pivotal, and really changed the course of the use or honing in on female-specific risk factors, because a lot of times we as clinicians don't focus on these female-specific risk factors, but we know that these female-specific risk factors, many of which occur during pregnancy, places our patients at higher risk for cardiac events. So if we have a patient that falls in that borderline to intermediate risk, but they have these female-specific risk factors, perhaps we want to be more aggressive in lowering their cholesterol and would want to start them on a statin. What are these risk factors we think about? As I made mention, a lot of them occur during pregnancy, so preeclampsia, gestational diabetes, gestational hypertension, premature labor. We also know premature menopause before the age of 45 or premature menses before the age of 12 are common risk factors specific to women. We also know that there are common risk factors specific to women, or disproportionately, I should say, affect women more than men, that include a lot of our autoimmune inflammatory conditions like rheumatoid arthritis or lupus, which I didn't list. We also know that, of course, psoriasis and HIV are inflammatory conditions that place us at a higher risk for cardiovascular disease. The guidelines also more recently wanted to separate it by ethnicity. And we know this from multiple studies that those of South Asian ancestry tend to be at a higher risk for cardiovascular conditions. So perhaps we'd be more aggressive in this patient population in terms of thinking about starting them on a medication to lower their cholesterol. Now, it's not just sort of these risk enhancers, but it's also labs when we think about risk enhancers too. And we know that anybody who has a persistently elevated triglyceride above 175 may be at a much higher risk for cardiovascular disease. And that's why our newer studies are actually focusing on medications that lower our triglyceride levels. We know that also we should be checking a lot of these more specific labs, particularly depending on the individual patient. So for example, somebody who has a high sensitivity CRP above 2, that may deem them at a higher risk for a cardiac event, and we may be more aggressive and want to put them on a lipid-lowering medication. Similarly, lipoprotein a, I think, is gaining a lot more research and insight, because we know that this is a very common risk factor for cardiovascular disease. Patients that we should be checking lipoprotein a on are typically patients that have a very strong family history of cardiovascular disease. And if we see that they have levels above 50, this puts them at a very high risk for a cardiac event. Unfortunately, to date, we don't know the best management to lower one's lipoprotein a. Some studies out there show maybe the use of PCSK9 inhibitors, but I think we just need more data to really figure out how best to lower these types of markers. Similarly, ApoB, having an ApoB above 130 is equivalent to having an LDL above 160. And we typically check ApoB for those that have very elevated triglyceride levels. And similarly, ankle brachial index is continuously showing up because the guidelines really stress that if anybody has an ankle brachial index less than 0.9, we may want to be more aggressive in lowering their LDL cholesterol. Now, I want to just briefly talk about other issues specific to women, as the guidelines really focus in on these issues, and I think it's so pivotal. So as I talked about just in this last slide, we want to consider our women-specific conditions like premature menopause when discussing lifestyle and statin benefits, but we also want to think about women that are of childbearing age who are sexually active and taking statins, because we know that statins are teratogenic and they can be harmful to the baby. So we want to ensure that we're educating our female patients that they're on a reliable contraception. We also want to ensure that if they're planning on becoming pregnant, they should stop their statin within 1 to 2 months before attempting pregnancy. Any woman should stop their statin as soon as their pregnancy is discovered to reduce the risk of any harm to their child. Now, I mentioned calcium scores. So really, again, focusing in on our borderline risk or intermediate risk group. The guidelines suggest that if you have an intermediate or higher risk after we use our 10-year ASCVD risk calculator, you may benefit from being placed on a statin. But what about in that sort of group that remains on the fence? Because again, in that 7.5, which is that intermediate risk group, 7.5 to 20%, we can have that shared decision-making with our patient where, yes, we may suggest that the guidelines say you would benefit from the use of a moderate intensity statin, but they may remain on the fence of starting a statin for an X number of reasons. Or they may be in that borderline risk group where it's really about shared decision making. And let's say we went through the risk enhancers that I talked about, and even despite going through the risk enhancers, they still remain on the fence. We then may want to use a calcium score. So a calcium score is really just an X-ray where we're able to look at if there's any calcium in the arteries of our heart. And that calcium is plaque that's hardened up. And we know that overall, we tend to use calcium scores as screening tools, but for the guidelines and for all intents and purposes, they're not using it for screening tools, they're using it for decision makers. And one thing that I can say is that if you have a calcium score and your calcium score is 0, and you are in that group between 7.5 to 19.9, it can drastically lower your risk of having a cardiac event, where it nearly halves your risk. So let's say, again, you were from 7.5 to 19.9%, it could halve your risk to the point where you probably can get away with not having to be started on a medication to lower your cholesterol. So this patient population, what we probably would suggest is just lifestyle modification, and also maybe repeating their calcium score in another 5 to 10 years to see what we're dealing with at that point. Now, this here is very important because, as I mentioned, we would never, never, never consider the use of a calcium score in those that are deemed high risk. So anybody with a risk greater than or equal to 20%. And why is that? Because even if your calcium score is 0, you're still above that 7.5% threshold. So we know that even if your calcium score is 0, you would still benefit from the use of a statin. Now, what about those that if we check their calcium score and they fall into that 1 to 100 area? Well, we see that a lot of them, really from 7.5 to 19.9%, really hover around that 7.5 area. Maybe the lower risk gets a little bit lower, but the fact is that we try to err on the side of caution. And we know that if you have any evidence of calcium in your arteries, it's a conversation to have with your patient, but for the most part, that by definition implies you have heart disease. It's subclinical heart disease, but it's heart disease nonetheless, and we probably are going to want to be very aggressive in terms of putting you on a medication to lower your cholesterol. Now, what about those that have a calcium score above 100? And this is where the guidelines say anyone with a calcium score above 100, irrespective of their risk enhancers, if they fall in that borderline and intermediate group, should be placed on a statin, because we know that a calcium score above 100, right, in all categories are well above that 7.5 mark. So again, a calcium score can be a game changer for us as clinicians to think about or to use, particularly for those patients that that may remain on the fence in terms of wanting to be started on a medication, or we're contemplating the benefits of the use of a medication. Now, who should know if their calcium score is 0? And that really brings into the point the power of 0. So once again, any patient reluctant to initiate a statin who wishes to understand their risk and potential for benefit more precisely. Any patient concerned about a need to reinstitute a statin therapy after they discontinued it for maybe a symptom, a statin-associated symptom. We also know the guidelines suggested in older patients, so any male between the ages of 55 to 80, any female between 60 to 80 who has a low burden of risk factors who question whether they would benefit from a statin therapy, or really any middle-aged adult between 40 to 55 who has a 10-year risk that was calculated in that borderline risk, 5% to less than 7.5%. And this really is, I think, here to really summarize to you, when we have that patient population for primary prevention that doesn't fall within that LDL above 190 or is not diabetic between the ages of 40 to 75, the first thing we want to do is estimate their risk. The next thing we want to do is personalize them, right? So we know that not all patients are the same, so we want to personalize them by looking at their risk enhancers. And we may want to reclassify them by utilizing a calcium score. That way it's easier for us to figure out, is it lifestyle modification by itself or lifestyle modification with drug therapy? Now, the last slide right now is really going to be honing in on this age group. And I think it's so important that the primary prevention guidelines added this age group, because this is where we can do a lot of good in terms of screening. So really anyone between the age of 0 to 19, particularly if you have a strong family history of early heart disease, we should start thinking about familial hypercholesterolemia because, as I said, it's not as rare a condition as we previously thought. Similarly, those between 20 to 39, if you have an LDL cholesterol above 160 or a family member, primarily a first-degree relative with premature ASCVD, we may want to start you on a medication to lower your cholesterol, even though you're in that young age group, because we know that your risk in the future of having a cardiac event is very high. So in summary, LDL cholesterol remains to be the major driver of atherosclerotic cardiovascular disease. We as clinicians want to emphasize a heart-healthy, plant-based diet, lifestyle modification, including exercise as well. We want to treat our patients aggressively for secondary prevention, meaning those that have already known atherosclerotic cardiovascular disease, to an LDL threshold of 70 or less. We want to consider the use of non-statin lipid-lowering agents, and we want to use guidelines that recommend the use of ezetimibe first and then PCSK9 inhibitors for appropriate patients. We want to treat patients with an LDL cholesterol above 190 and those that are diabetic early and aggressively. And for those from a primary prevention perspective that don't fit that category, we really want to assess their ASCVD risk. If they're between the ages of 20 to 39, it's their lifetime risk. If they're 40 to 75, it's their 10-year risk. So really, every 10 years or so, we should be checking it. And we want to ensure that we have a clinician-patient risk discussion that occurs really before starting them on a statin. And that could be looking at enhancing factors to personalize their risk and decide if a statin is important. And when a risk decision is uncertain, we may want to use that calcium score to determine if the patient should be started on a medication or not, and really reclassifying them. So let's go over the 4 questions that I had asked at the very beginning, because hopefully with the talk, you now have a better understanding of what these answers may be. So just to kind of refresh your memory on the first question, according to the 2018 blood cholesterol guidelines, a patient with which of the following is considered to have very high atherosclerotic cardiovascular disease risk? Is it 1, hypertension and diabetes, 2, greater than 1 acute coronary syndrome in the last 12 months, 3, an LDL cholesterol above 100 on a maximally tolerated statin, or 4, symptomatic or asymptomatic peripheral arterial disease? And just to remind you, I wanted to include the very high definition, and the answer to that is actually 2, greater than 1 acute coronary syndrome in the last 12 months. Where many of you may have got confused is thinking, well, maybe 4 is the answer, is that it's only in those that have symptomatic peripheral arterial disease, not asymptomatic peripheral arterial disease, that deems them at a very high risk. So this is the group where we would want our LDL threshold to be well below 70. Question number 2. Clinical outcome studies of PCSK9 inhibitors have reported which of the following in patients with peripheral arterial disease or polyvascular disease? Is it 1, an increased adverse event rate in patients with peripheral arterial disease compared to no peripheral arterial disease, a similar reduction in LDL cholesterol and ASCVD event rates in patients with or without peripheral arterial disease, 3, reductions in ASCVD event rates related to the intensity of background statin therapy, or 4, greater reductions in ASCVD event rates in patients with more extensive vascular disease. And based on the ODYSSEY trial that I had showed you, we know that the more extensive vascular disease, the better the benefit from the use of PCSK9 inhibitors. So the answer to this question is 4. And I want to use this again as an opportunity for us to stress the importance of treating our patients with peripheral arterial disease as aggressively as we would treat them if they had coronary artery disease, ensuring that their LDL is well below that threshold of 70, and understanding that our non-statin therapies can be used for peripheral arterial disease as well, just as it could be used for those that have had a cerebrovascular event. Now, question number 3. Doing which of the following may improve the chances of prior authorization for PCSK9 inhibitor therapy? Is it 1, ordering an LDL cholesterol fractionation, 2, conducting carotid Dopplers and including the results, 3, including letters from patients confirming adherence to therapy, or 4, providing hospitalization records for patients with a history of ASCVD. If you can remember our case study Rosa, what we ended up doing for her is we provided hospital records. And with that, the insurance company finally approved her PCSK9 inhibitor. So the answer is number 4. Last question. We have a 70-year-old man with a past medical history of peripheral arterial disease. He is symptomatic with claudication in his right lower leg. He has an ankle brachial index of 0.75, which is significantly abnormal. He has hypertension, diabetes, and an LDL cholesterol of 82. He's currently on 40 milligrams of rosuvastatin. Which of the following would be appropriate at this time? Would you prescribe ezetimibe, switch to atorvastatin 80, request a prior approval for PCSK9 inhibitor therapy, or maintain a current therapy because he's fairly close to his threshold? And we know that we should never do answer 4 because we want to ensure they're well below their threshold of 70. And based on the LDL cholesterol guidelines, it would be number 1, which would be first to start the use of ezetimibe. In real practice, you may, however, before even thinking about ezetimibe, think about getting prior approval for PCSK9 inhibitors. So with that, I'm going to open it up to any questions. And I know that I asked a series of questions right now, but I'm going to hand it over, actually, because I think we're a little bit over time, to Susan to sort of go over any housekeeping that we may have, and hopefully you've learned a lot from this lecture today. So thank you.
All right, everyone, that wraps us up. We'll let you get back to seeing your patients. We hope you join us next month on March 19th for the 3rd CME in the series, When Do I Need a Specialist to Continue the Women's Heart Health? Please make sure that you've received the instructional email within the next hour. If not, please get in touch with me at 928-699-4797 or email me at susan.fourier@dignityhealth.org. I'll keep the WebEx on for a few minutes if anyone's having problems with it or if you have any questions. And again, thank you for attending our virtual CME Lunch and Learn.